So I'm really pleased to start this session on looking at the impacts of the pandemic on the long-term care workforce, and also have and I'm delighted that we have a combination of papers. We start with one from Ireland, presented by Conan Brady, that's going to be looking at the mental health of nursing home staff in Ireland during the pandemic. Then we'll be hearing from Eileen Kuhlmann, who's been developing a comparative framework for and cross-country analysis for the European countries, looking at the new threats of COVID-19 and the long-term care migrant workforce. And then we'll go even further to the OECD, and we'll be hearing from Eileen Rocard on rising from the COVID-19 crisis, workforce policy responses in the long-term care sector. Clearly, a very quickly moving area. I think we had some news from Northern Ireland yesterday also of changes in pay, for example. So I think this is an important area to share international learning. So thank you all. And if you are ready to get started, Conan, it's all yours.
Sorry, just on mute there. Can you see those slides?
We can see it, and if you want to project it.
Let's see. Apologies, I'm a little bit late. There's a storm here at the moment, so it's slowed everything down. Let's see now. Just.
So you can go to or you can go to the bottom. There's a symbol with a box and a bit to the right. A bit more to the right.
Oh yes, there we go. There. Okay, that's great. Can you see that now?
Not yet. So you click on the one that looks like a box with
the arrows coming out of it. Yeah,
to the left.
For me.
To the left.
1 second. Usually I'm not so bad at this, so I'm not sure what's happening today. I'm sorry.
Next to the macro, to the size at the very bottom.
Yes, no, it's not
to the left. No, it's the left.
To the left. Ah, yes.
Yeah, that's
there we go. Okay, thank you. Okay, so thank you very much. My name is Dr. Conan Brady. I'm a psychiatry higher specialist trainee working in Dublin and Monaghan. This paper we published recently in the International Journal of Geriatric Psychiatry. It was a survey we ran from November to January last year. The first phase of projects. We're actually in the process of recruiting for a second phase at the moment. And this is some of the descriptive data from the first paper. We'll be having some more data coming out from this, but this is the initial paper that we've had published so far. So I need to give very little background to this group, I would say, but just to give some context for figures in Ireland. So in the first wave of the pandemic, 56% of all COVID-19 deaths in Ireland were in nursing homes. So a huge figure, larger than some of the other countries selected there. I'm sure the figures are pretty similar. As you know, where COVID-19 transmission is widespread in the community, it just gets into nursing homes everywhere. That's pretty well understood at this stage. There's been very little research on nursing home staff mental health, though, internationally, actually. Before this paper, there was only one quantitative study was published when we started collecting data for this. That was in Italy, and that estimated the prevalence of moderate to severe symptoms of PTSD at about 39%. So we set out to figure out if this was happening in Irish nursing home staff. And the method we used was an online anonymous survey from November to January 2020. And the recruitment process, we kind of went through every nursing home that we could. They're all affiliated with Nursing Homes Ireland, who are a representative body for the private and voluntary sector in Ireland. About 90% of all nursing homes in Ireland are private or voluntary, but the remaining 10% are run by our national health service here, the Health Service Executive. So our measures, we collect basic demographic information. We also have a free text box with for some qualitative data, which isn't reported on here. We also look at the extent of COVID-19 exposure in nursing home staff, quarantine experience, history of contact with COVID-19 positive acquaintances. The measures that we use, the mental health measures, were, I suppose, the main ones were the impact of event scale revised, which is a measure of post-traumatic stress disorder symptoms. And so their hypothesis was that, nursing home staff are probably seeing really traumatic events. There have been well-publicized instances of high mortality in some nursing homes, obviously across the board in Ireland, as happened elsewhere. And also just, I suppose, there may have been some post-traumatic stress symptoms from just general work stress, difficulties in the work environment, etc. We also have the WHO Wellbeing Index. This is a measure of well-being, but it corresponds pretty well to depression and low mood, actually. So there are pull-off scores for that. We had 2 Likert scale items on suicidal ideation and planning over the past week. We also looked at this moral and injury event scale. This is a scale that that's originated from combat research, combat veterans research, looking at moral injury, which is a psychological distress experience when one has to witness or see acts that go against one's moral code, or where you feel that you've been betrayed by a higher authority. So obviously that's very relevant in combat settings, but in the context of the COVID-19 pandemic, it's hypothesized that this is very relevant for healthcare workers, where they've had to be involved in the allocation of scarce resources, for example, or in nursing homes, an example could be where nursing home staff are forced to implement visiting restrictions or cancel group activities, for example. We looked at some other measures here as well, a coping scale. We also looked at perceptions of the COVID-19 outbreak. I'm not really focusing on those here today too much when we look at the first few measures. We also looked at this workability scale, which is a measure of whether or not work felt that their workability was sufficient or not, or if that decreased in the past year. So I'll skip the analysis for the sake of time here, but I would, if people have questions about it afterwards. Just in terms of the response and the results, so we had 390 responses. We broke it down as nurses, healthcare assistants, and others, so patient staff, household staff, administrative staff, activity coordinators. We characterized those as one group for the purpose of analysis. The majority of our staff who participated in the survey were female, and the majority were white. Demographics, so we found significant differences between nurses, healthcare assistants, and non-clinical staff in their age. Healthcare assistants skewed younger overall. Their ethnicity, with nurses skewing more non-white. There were lots of nurses of Indian, Filipino heritage and origin working in Ireland, Irish nursing homes, and years experience as well. So healthcare assistants tend to have less experience overall. So yeah, and there's also the most experienced group as well. They're less likely to report less than 5 years experience. In terms of exposure to COVID-19, so about 1/3 of staff reported having quarantines at this time. This is, about less than a year into the pandemic, I suppose, in Ireland at this time. A majority reported no history of COVID-19 infection. I imagine that's changed significantly since then as well. Of those who contracted COVID-19, only 5% reporting having symptoms for less greater than 9 weeks. Yes, but only about 1/3 reported not having fully recovered. Most nursing home staff report no history of caring for residents with COVID-19. So with respect to our score, these are the mental health measures now. So this is the WHO Wellbeing Index. I suppose this is the measure I mentioned was a fairly good indicator of the level of depressive symptoms in this population. So WHO score of less than or equal to 32, indicating poor well-being. We found that to be 39% of staff reported scores consistent with that. And that figure lies at the higher end of the range for prevalence globally of depressive symptoms in the general population during the COVID-19 pandemic. You can see the range there. Significant differences were noted between groups with more nurses reporting poor well-being and more healthcare assistants reported normal well-being. And the scores consistent with likely major depression. So we would consider that to be sort of in the range of moderate to severe depression, actually, or clinical depression would be another way to describe it. Was reported by 20% of all staff, with no difference between groups. So all groups of staff were affected equally. With respect to suicidal ideation and suicidal planning, so these figures were quite concerning. They've been kind of reported on in the Irish media to some degree over the past few weeks. 1 in 7 staff reported thoughts of suicide, and that's only in the past week. And 1 in 11 reported some plans to end their life in the past week, and it's a really shocking figure. It's hard to actually have good comparative data on this internationally because there's very little data on suicidal planning. Actually, most of the data in healthcare workplaces on suicidal ideation and planning as a combined item. Certainly, the suicidal ideation prevalence here seems to be higher than what's seen in most other healthcare workers and hospital staff, and even higher than some. Actually, there's very few nursing home studies reporting on suicidal ideation to date. So the impact of event scale revised. So we found that 45% of all staff reported moderate to severe symptoms of post-traumatic stress disorder. So this is not a diagnostic scale, it has to be said. We're not diagnosing staff with post-traumatic stress disorder, but it certainly needs to be very concerning for staff to have a diagnosis. What we really want to know is if these problems are persisting and if they're causing any functional impairment with them as well, of course. But this figure is very high. It's in the same range as what we saw in Italy, actually, just some staff. So I know we have a pretty small sample size here, but certainly there seems to be a commonality to experience internationally, I think, in nursing home staff across the board. And interestingly, we didn't find any differences between groups of staff with respect to these symptoms. So I suppose, look, we all know that working in nursing homes, every staff member has a clinical role to some degree, and obviously you tend to have very close relationships with the residents, no matter what their role is. And I think this finding kind of highlights that nurses, administrators, catering staff, etc., all experiencing similar levels of post-traumatic stress. With respect to moral injury event scale, so this scale has several subdomains looking at transgressions by self, which is where you've done something that you feel is transgressed your moral code to some degree. Transgressions by others, which is where you feel others have done things that transgress your moral codes, and there's also the betrayal scale, which is where you feel betrayed by authority figures in your workplace. So the mean score was 20.8 from standard deviation 9.1, and there's no cutoffs for this scale, unfortunately, as yet. It's a pretty recently described scale. I think there's a group in the UK working on cutoff scores at the moment. But this figure was significantly higher than that US hospital staff at the beginning of the pandemic. I believe there's that actually from the NHS recently, and I think their mean was 15. So again, I believe our score for this group that we have in this study is higher than that again. So it seems that the nursing home staff have higher degrees of moral injury than hospital staff internationally in any case. There were significant differences between groups on the total score and the transgression by others score, with healthcare assistants reporting significantly higher degrees of moral injury than non-clinical staff. So I suppose we'd be speculating here as to why that is. The study doesn't actually tell us why that is or not, but I suppose one possibility could be that healthcare assistants obviously tend to have very close bonds with residents and may have been less involved with some of the decision making in terms of visiting restrictions, implementation, etc. And may have been difficult for them. So I'm not sure about how much time I have left, actually, if I want to talk about the coping scale or not. So
don't worry. We're doing well because we started a bit earlier, and we really want to hear about this.
Okay, good. So yeah, look, this is a coping scale looking at different types of coping styles, basically. So it groups into two main categories, which are approach, which is kind of positive coping styles, I suppose, it will be another way to describe this, and avoidant coping styles. And we're doing further analysis on this to see if these coping styles were protective or mediated some of these other factors. And we'll be releasing that data soon. But just in terms of the scripted data on the groups here, the groups differ with nurses using more positive or adaptive coping styles more than non-clinical stuff. Although I would note that it doesn't seem to have protected them, broadly speaking. Certainly, in terms of depression anyway, everyone seems to be equally affected. So that's one thing to highlight here. There's also significant difference for use of religion as a coping mechanism. This is a minor subscale on this measure as well. And there are no differences in terms of using humor or avoiding coping styles, so they were all similar across the groups. So the workability, so 25% of all staff reported their workability is insufficient, with no differences between groups. Unfortunately, there's no previous comparative data for nursing home staff. But actually, we've seen similar levels of insufficient workability in healthcare workers, Irish doctors specifically, before the pandemic. And this figure is associated with burnout, and we didn't measure burnout specifically in this study, but certainly I know there's been some data on that internationally. So look, just the key points to summarize is the first systematic facility of public around nursing home staff experience during the pandemic so far. It's only the second such report actually at the time. I believe it's been since actually, or even more actually. I'm sure I could be correct on that. The prevalence of symptoms of PTSD and intensity of moral injury in approach nursing home staff is significantly higher than that of hospital staff internationally during the pandemic. Obviously, very concerning though is suicidal ideation and planning, and significantly more nurses reported poor well-being, despite being more likely to utilize adaptive coping styles, and healthcare systems report a significantly higher degree of moral injury. So, yeah, as I said, this has been published recently, and it's had some national interest in Ireland, and actually some international interest as well. Actually, I think the BBC were contacting one of the press officers looking for information on this. They've been covering this topic recently, I believe, looking at nursing home staff. So we are, as I said, we're in the process of releasing some more papers. There's a policy paper and a paper looking at modifying factors, and we are recruiting to the second phase of the survey at the moment. So if you haven't seen the Irish nursing home staff, please let them know that the survey is running. We're going to be doing a longitudinal analysis to see if these problems have persisted. I suppose some of the flaws in the study, look, you know, it's reasonably small size. I think recruiting this population is very difficult. The sector is so fragmented. I found it very difficult to actually get people involved in the study, and I rang nearly every nursing home in Ireland at this stage. I think maybe some of them twice over actually, because we're recruiting again at the moment. And I suppose if I go back and do it again, actually, one thing we don't really ask about the working conditions of staff, I think is really important. Certainly, you know, we don't know if a lot of these problems were there before the pandemic, because there's been so little research in this area before. So, you know, I suppose we're hoping to mitigate that to some degree by doing the second survey now. We can see if these issues are persisting or not. Now that visiting restrictions are eased to some degree, that staff are vaccinated, residents are vaccinated. So it'd be interesting to see if they change or if they stay the same. But look, I'm in the middle of a clinic, so I will have to leave at some point, but I'm happy to answer any questions now. I don't know if that suits or not, but
oops. Sorry. Thank you very much, Conan. And so do you have a couple of minutes for questions?
Yeah, please. Yeah? That's okay. Yeah.
So yeah, if anybody has some questions, I've shared the link to the article that you have published.
Thank you.
And I mean, these are very concerning findings and we really would be very interested to hear more about when you have more findings from the next surveys. I was wondering if anybody would like to comment. Perhaps if you stop sharing the screen, we can see also if you want to raise any hands or any questions up there. And we will have also, I see Eileen Salonikis here, who will also be presenting this afternoon on a survey of social care staff in England. And I was wondering if, Eileen, if you see some parallels with some of the findings that you've got for later.
Yes. It's quite interesting to hear all about this. To be honest, we didn't have that many detailed well-being or kind of mental health related outcomes in our survey, but still I was quite surprised to see all of the outcomes, you know, being so negative, as in not very positive, I suppose. But yeah, I mean, I will read the paper with interest. It's quite because I did some search online just to see if there's any work in this area, and as Conan mentioned, there is very little, and especially, you know, in the post-COVID era and how that compares with all the experiences and health impacts prior COVID, there's not much. So we desperately, I suppose, need this kind of work. And the other thing that sort of confirms some discussions we had with other colleagues is the impact of those negative experiences in terms of the PTSD. And there was some evidence in what Conan reported. So again, it's kind of confirms all the concerns that have been raised, and it's something that we will continue seeing. I think we're still at a very early stage, and I think, you know, this is the long-term impact that we will see in other studies coming up. But thanks, Conan, that was really helpful.
Thank you.
We focus more on abuse, so it's not so much on mental health, but we will report on some general health outcomes, and then more specifically about different types of abuse later on this afternoon.
Okay, look forward to hearing about it.
And we will be recording it because I know you have to go back to clinic, Conan, and you'll be able to access the other presentations as well. Any other questions for Conan before he needs to go? If not, we can move to so raise your hand very quickly if you do. And if not, I'm starting to switch then to the next presentation. So delighted to have Eileen Kuhlmann here. We met earlier in the year a bit by chance in a different topic, a slightly different topic, and we realized shared interest on thinking about COVID and long-term. I'm really happy that you have accepted the invitation to come and join us and present, Eileen. So if you want to start sharing your screen, see if that works, and if not, can help from here.
I was expecting these problems. It does not work,
No,
and I don't know why.
I can share for you if you like.
That would be very kind. I'm really sorry for that, but
No,
there
it's
must
okay.
be glitches in my PC.
It happens.
It happens. Yeah. Thank you so much for giving me this opportunity to be with you. And thank you, Adelina, for the nice introduction. So I was so pleased yesterday when I heard, next to many other interesting findings, of course, but specifically, I was so pleased when I heard how much several of the presenters from your country reports mentioned or were concerned about the health workforce. And that is really something that I did not expect, because usually the health workforce is not mentioned. And that is, as you see, this is my main area. I'm a president of the Health Workforce Research section of the European Public Health Association. And so that you know, I'm a little bit biased towards the health workforce, of course. And we thought last year, more or less during the first wave, we can't talk about the health workforce without thinking of long-term care, and we can't talk about long-term care health workforce without thinking of migrants. And we found that there is nearly nothing in the discussion, at least in spring 2000. In spring last year. So, and that is the background on this study. Next slide, please. Yes, so we wanted to bring the migrants carers into the discussion and understand what is the situation actually during this COVID-19 pandemic. Next slide, please. And there were two aims. First, as I said, we wanted to highlight the situation of the migrant carers, who are usually forgotten in the policy and COVID-19 discourse. And we also wanted to highlight a need more generally for a multi-level and transsectoral European approach to the health workforce. Next slide, please. So our methods were totally explorative. I'm sorry, I can't provide this kind of really important data, as we heard yesterday very often, and as we heard from the previous presenter. We worked totally with secondary sources and with experts. because we felt just start somewhere and hopefully then motivate others or find a way to move on with more collection of primary care data. And we included 5 countries that were Austria, Germany, Italy, Poland, and Romania. And the reason behind was also that we were just thinking to have a variety of healthcare system in the European Union, a variety in relation to the long-term care systems, and also in relation to the health systems and the COVID-19 situation. Maybe you remember, and we heard that very often yesterday, the situation at that time was very different in Italy and in Germany, the COVID situation. So next slide, please. And I'm coming to the results. And first, we found that this simple was that, could you go back, I think? Yeah, thank you. I was thinking something was missing there, because I would like to very briefly explain what we did very briefly. We developed a very easy to handle tool, as I said, as we didn't have the data we were wishing for. And we decided to use 4 different items: the LTC system in the country, the LTC health labor market, the long-term care labor migration policies, and the specific migration carer policies during the COVID-19 crisis from about March to May 2020, which was our time when we did this research. So next slide, please. Now I come to the results, and at first we found that this very simple framework worked, because these were, at least we found some data, and we found some experts, so that we could start with doing kind of comparison in a very explorative manner. And we really found a need for this more complex approach that introduces different levels of health workforce governance and health systems. Next slide, please. Yeah, one key finding, first, we found that conditions of, first, undersupply or strong undersupply of carers in the country, coupled with cash benefits and with a culture or strong culture of family responsibility for care, was a very strong trigger for a high inflow of migrant carers who were channeled in low-level labor market segments or in the informal care sector. And that we thought is an important finding, which also shows us, if we think about the migrant long-term care workforce, then it's not enough just to look at the workforce. We must have a much broader look. If we want to bring in some change and innovation, we must have a much broader look on the system. Next slide, please. So, could you go back? Yeah, thank you. So, and the next result is that what many, of course, many colleagues found, COVID-19 is a focal glass, really, that makes fragile labor market arrangements of migrant carers visible, as it makes many other problems in healthcare and in society visible. And in our case studies, we found that the long-term care system and policies create high risk for the individual carer, for the population, and for the health system. So it is not just talking about individual health, carers are not just talking about one sector. It really impacts the healthcare system and the society. And next slide, please. I would just like to give you a very brief example using Romania as a case study. What this means, if we are saying there are these three dimensions where we found very alarming effects of these kind of policies. So in the Romanian case, we called it COVID-19 turns migrant care into a showcase of risky health conditions. Briefly, we found at that time a situation where COVID-19 started in Italy. The borders closed. Italy has a very high proportion of migrant carers from Romania. They were pushed back to Romania. They were because the borders were closing. So these carers went back to their original region in Romania without having any kind of proper testing and controls in place. So very quickly, in that area in Romania, COVID-19 incidences went up very quickly. The migrant carers, of course, were very much worried because they lost their job and they needed some money, so they were hiding the symptoms. Not there, but many of them were hiding the symptoms. That brought a situation where COVID-19 went out of control in these Romanian regions, which was quickly among the most affected region in Romania. So that means there was a risk for the entire society. Of course, also a very strong individual risk for the migrant health carer. And then after some time, Italy, also Austria, found out that they desperately need these migrant health carers because the situation was very, very difficult in the care sector. As you know, the older the people, the higher was the risk of getting COVID-19. So they found the countries found agreements to bring the migrant carers back, even in a situation where borders were closed, and that again put a very high risk on the individual migrant carers that were more or less forced because they needed their job, they needed the money, they were more or less forced to go back to a country in a situation of very risky health situation of the pandemic. And there was also from a country perspective, a system perspective, Romania accepted the loss of these carers, although they really desperately needed them for their own countries. And that is next slide, please. That case really shows us that what we call the mobile carers or migrant carers turned into faceless numbers. It was no longer about looking at the person behind that, just to satisfy health labor market demand, and sending countries also accepted a loss of care, a worsening of the care situation in their own country. And I think it's no need to discuss that anymore. It's very clear this is not a healthy and not an acceptable situation for Europe. So we should really look for other ways of dealing with this, because from a public health perspective, it is a risk for the individual, for the society, and for the health system. So next slide, please. And the second next, because I skipped that, we also had an example from Italy. Next slide, please. Which I don't go into detail because of time. So in the Italian case, we can show that the weak coordination between hospital system, residential care, home services may reduce opportunities to respond in a more appropriate way to COVID-19. And that also triggers these push and factors for migrant health carers. I come to the conclusion. Next slide, please. So 2 conclusions to mention. First, there is really an urgent need to include the migrant carers in public health and in all health workforce policy and research. There's not longer acceptable to treat that as a separated sector, what is kind of always marginal from a health policy perspective. So this COVID-19 and the migrant carer situation has shown us how important it is really to integrate that. And yesterday, I know we heard much more about that in your country cases. So next slide, please. And that also means the situation can no longer be solved only on a national level, because what we really need is a more European approach, a European research, European monitoring system. And with this, next slide, please. With this, I want to close and really again, thank you very much for giving me the opportunity to being with you. And I would be very much interested to continue the collaboration, or to find closer ways of collaboration. And what I presented is published. You see the link here. So hopefully that gives you at least a quick idea on our key messages. Thank you very much.
Thank you very much, Ellen, and very strong policy message here. And I was just thinking yesterday, we one institution that we didn't bring in, and that's actually my fault, it was the European Commission. And I do think this is an area where maybe some coordination at European level is very much needed. But we do have the OECD with us, who have been doing an amazing job at collecting data. And before we go on to Eileen, I don't know if there's any reaction, comment you'd like to make to Ellen, any question, and any thoughts, Ellen, on how we could push for this policy action. And what do you think might be some mechanisms that could be used?
And then, thank you. Of course, I have no solution for that. But what I was yesterday spontaneously thinking, you have this wonderful report, which I was not able to read in full. But I was spontaneously thinking, maybe there is an opportunity to work with a smaller team and just extract the information on the health workforce. Because my impression was there is quite a lot of information in, more than we have from other sources, and maybe that would be an opportunity to start and to develop something more related to a research proposal also, because the problem is always that you can do this kind of research that we have done without researchers. But if you really, we really need data, and yeah, I'm also grateful for the OECD data, but we also need qualitative data, and then you need to find money. But that was what I was thinking, and I would be really very much interested to have a closer look on that. And the report is published, so to use it also with putting up this lens of the health workforce.
That's a great suggestion. And I mean, one of the things in the International Living Report is that we have these questions, but for some, we haven't had time to do it for many yet, but we do have an overview section which is a place that we hope that over time we'll be able to look at each of these questions, see what's coming through the countries, and start to write something. And we do also try to identify all the people who are interested in each area, each question, to help facilitate some of this collaboration. I think we can put that in our to-do list for a collaboration that could emerge from this. So thank you very much. I don't know if there's any other question. We're going, for now we'll move to Eileen. You can also put the questions in the chat, and we may have other spaces. And I see that Daisy has shared the link to your paper as well in the chat, in case anybody would like to read it directly. So thank you very much, Ellen.
Thank you.
Eileen, if you want to go ahead.
Yes, I will. I will share my screen from here, and I believe I need to swap. Okay, so good morning or afternoon, everyone, and thanks for inviting me. I also would like to thank the previous presenters for their interesting insights. So I work at the OECD. Thank you, Adelina, for the nice introduction. And in the last 2 years, our LTC team has worked on a working paper on the effects of the COVID-19 crisis on long-term care in OECD countries. The working paper was published end of October, and we hope to publish a policy brief that summarizes the key findings in the coming months. I would like to dedicate 1 minute to the title I gave to my presentation, Rising from the COVID-19 Crisis, Workforce Policy Responses in LTC. We all know that the COVID-19 crisis has been very tough for LTC, but I also believe that it is through these hardships that LTC has been under the spotlight in the last years, and I wish that this can help strengthen it. So during my presentation, I will talk you through the COVID-19 impacts and the pre-existing challenges with a focus on the workforce. I will then highlight the main policy responses in OECD countries, and I will draw some conclusions on how we can see the crisis as a learning opportunity. So let's start with the COVID-19 impacts and the pre-existing challenges. COVID-19 took a heavy toll on LTC recipients. About 40% of COVID-19 deaths were among LTC residents, on average across 25 OECD countries. That being said, it's important to say that the comparability of these data requires caution, as the methodology varies to a certain extent across countries. Available data on cases in LTC facilities is scarce, but suggests that the positivity rate and the incidence rate among residents often mirror that of LTC workers, with larger peaks among LTC residents during outbreaks, as you can see here with the positivity rates in England. So basically, that means that for workers in long-term care facilities like nursing homes, that when there is a cluster in their facility, they are more likely to fall ill and to have to take sick leaves. And for workers who are not sick, that means that they have to take care of more of frail older people who are infected or with a higher risk of infection, while also enforcing stronger containment measures. So the pressure on the workforce becomes very important, especially in facilities with staff shortages. And actually, the issue of workforce shortages is not new at all. It is important to remind people that before 2020, the LTC sector was already facing multiple challenges. The working conditions are often poor, which is a main driver of staff shortages. And LTC spending is much lower than healthcare spending, suggesting a structural underinvestment. And in addition, quality standards are often insufficient, especially for home care, and not appropriately monitored. And last but not least, the insufficient coordination across all the stakeholders does not help. LTC is fragmented across the health and the social sectors, across states, counties, municipalities, and across the public, for-profit and not-for-profit providers. And as I said, poor working conditions contribute to workforce shortages. The OECD average of the number of LTC workers per 100 people aged 65 and over was 5.2 in 2019, slightly lower than in 2011 when the rate was 5.3. So basically, population aging is slowly outpacing the workforce across OECD countries. And the rate is 1 or less in 6 OECD countries. A slide on the money. Underinvestment has an impact on workforce shortages and poor working conditions. On this graph, you can see that LTC expenditure is well lower than health expenditure as a share of GDP for 2019. Across OECD countries, the health and social components of LTC were estimated at 1.5% of GDP, while total health expenditure was estimated at 1.9% in 2019. So since the start of the pandemic, countries have faced these workforce challenges in different ways. And I will now present the most common policy responses related to the workforce. So let's start with something relatively obvious for a pandemic. Basically, workers have to know what to do when they face an emergency. But that was not the case in all countries. In 8 countries, specific guidelines for LTC were missing before 2020. And even though nearly all OECD countries published specific guidelines to face the COVID-19 crisis, the timing of the publication was important. And it won't come as a surprise that data suggests that the earlier the publication of guidelines, the better. In addition to guidelines, nearly all OECD countries created task forces to manage and coordinate responses. They consist of groups of experts organized at the national, local, or facility level. 45% of countries created specific task forces for LTC. And when task forces were not specific to LTC, experts were often included to represent it. However, almost 20% of countries did not include LTC experts in their task forces. Also, I want to highlight that the creation of COVID-19 task forces has mainly been an emergency measure, and only a few countries have permanent task forces in case of emergency, like Denmark, Korea, and Japan. I just showed you that countries developed strengthened guidelines and created task forces to manage and coordinate responses. At the same time, countries also understood that they had to address staff shortages to contain the pandemic. Nearly all surveyed countries took measures to recruit LTC workers or provide funds to LTC facilities that they could use independently, including to recruit staff. Over half of surveyed countries provided financial help to LTC facilities to recruit unemployed or former LTC workers. About 40% supported the recruitment of LTC students through financial help. In 7 countries, a pool of volunteers was available for emergency and was activated. And in 9 countries, LTC facilities received financial support that they could use independently, including to recruit staff. Also, 2 points I want to make. There were also other ways to address staff shortages. One way was that for some countries also suspended minimum education degrees or required qualifications for many tasks to allow for more task shifting. And 11 countries set up mobile teams to facilitate testing across LTC facilities. In addition, countries took measures to reward workers and make LTC more attractive, even though in most cases there were exceptional rewards. In 2020, about 40% of OECD countries surveyed OECD countries provided a one-off bonus, especially during or right after the first wave. Only 4 countries increased wages permanently, actually. And note also that 8 countries decided to improve working conditions of LTC workers as a part of programs designed to address COVID-19 in LTC. Since the data collection for this graph, which was in 2020, some countries have been taking steps to make LTC more attractive. And I have highlighted here 5 examples. I don't think that I have enough time to develop them, but I'm happy to share my slide afterwards. or to discuss this slide during the Q&A session. So I will now conclude with just one slide. I want to recognize that vaccination has been a game changer in the pandemic for long-term care and also for our societies, but the new variants might impact severely the LTC sector if the booster jab and the current containment measures are not sufficient. My hope lies in our ability to learn from our experiences. The previous waves can become useful learning experiences if they trigger improvements on several fronts, namely on workforce, addressing even more existing workforce issues by improving working conditions, staff ratios, on the data front to ensure standardized, comprehensive, and timely data collection. Also in terms of infection control, it might sound basic, but actually it is not, to ensure regular update of infection control protocols. And also I finished with a reflection on home care, because LTC recipients at home seem to be better protected from COVID-19. At the same time, we know that home-based options require adequate staffing, more sustainable resources, and support also to informal caregivers. So with that, I'll give back the floor. I hope you found my presentation interesting, and I also want to wish you a bit in advance happy holidays.
Thank you very much, Eileen. The holidays still seem a long way away for but it's nice to start thinking. So that was a fantastic overview, and thank you for collecting all this information. It's extremely important to have this data and be able, sometimes you have to demonstrate what you know is happening, and I think this is extremely important. Now, I've seen this quite a bit happening now in the chat, and we do have a question from, it was actually for Ellen, so I'm going to take a step back, from Olivia, whose mic wasn't working. So I'm just going to read it for her. So she's saying, I have worked on a qualitative project interviewing cleaners, cooks, and housekeepers working in care homes in the UK and their experience during the pandemic. Many of these workers were also of migrant backgrounds. However, I've noticed it was difficult to recruit this workforce in general into the study, I understand, and even more so if they have migrant backgrounds. Do you have any ideas on how to combat such recruitment challenges? And I mean, and also if there's others here who are doing workforce research, who also work with migrant carers, want to come in, please raise your hand.
Thank you. That is really a very important issue. I made the same experience, not for this project, as we didn't collect primary data, but for another one. And I think the only way is that you have more resources, more time, and that you develop direct connections to the communities. And that also means we are always talking about migrant carers, but these are very different people from different countries. So that is, from my point of view, the only way to get access. And I mean, I understand these people, because the key issue is they are working in the country, and they don't want to be always seen as the migrants with specific problems, and they don't want to be always brought to these problematic issues, and therefore it is understandable that they don't like to participate in our studies. But I guess it's an opportunity to get a connection to the community and then approach them through their own communities. But that takes a lot of time.
Thank you. And I've got a question for Eileen, which would be on the informal care workforce, as in not the unpaid carers, but the informal economy. And I just wondered if you could say a bit more about your sense of how much we're able to understand the scale of the issue in different countries. I know in Spain is a huge part of the long-term care workforce.
Yes, and it's very unfortunate because we don't have any good data to estimate the quantity and the importance. We know it's important in Spain, in Italy. We know it's important also in Germany, Austria, because it's easier to have an estimate of the number. About 60,000 registered people, I think, provide standing care in Austria, if I remember correctly. So we don't have what we try is to what would be very nice is to go back to Eurostat and to EU LFS, the surveys, and to try to cross tabulate and capture a bit more the quantity of people reporting themselves as as foreign born, at least. The latest struggle is that the confidentiality rules changed in Eurostat lately. And it's more difficult to have smaller sample sizes. So that's why it's also becoming more and more an issue to have a thinner disaggregate, well, more smaller sample sizes, basically.
Thank you, Eileen. Any other quick thoughts before we go? I see quite a lot in the chat. I also take as a request to add a sub-question in the workforce sections on that we have in the International Living Report on the migrant workforce. I do think we have plenty already. There's quite a lot of reports from the Austrian colleagues who've been contributing to the report on the situation of migrant workers in Austria, and thank you for sharing links. Any quick last words before we move to the next session?
It's Kathleen at UEA. May I make a very quick? Eileen, thank you for your presentation. This is not my area of expertise, so please excuse me if this sounds like a shallow question. When you showed the slide in which was about Germany and a few other countries, including the UK, and their responses, and you referred in the UK context to the more than £12 billion that's anticipated to be raised in terms of that levy. When OECD does that kind of research, does it follow up on what commitments are made? I'm not a politician, so excuse me, but I'm just going to add that there has been published skepticism on, even if it's not the amount that's going to be raised, how it will be allocated. So I just wondered, does the OECD have the resources and the time, etc., to follow up on claims that different countries make? Thank you.
So we don't follow up on countries' claims, that's for sure. But what we do is that when we publish reports, we provide updates, and we can point out at differences if that's relevant in the reports. But I completely understand the skepticism. At the same time, we receive our mandate from OECD countries, and we have a preference to show the data provided by countries.
Yeah, I hope my question didn't put you on the spot.
Can I come in and help out a bit here? The OECD can always show if there's a difference between the announcements and the data that they're able to collect, if I understand correctly. So you can show if there's data, that's what you can highlight. I do think that international organizations have a function and a role, and of course they have a mandate from the countries. I think having a platform that's independent and research-led also allows for a bit more freedom, and I think I'm going to leave it here. But thank you, that was a great answer and a great question at the same time.